Hi there, I'm Valerie. I'm the Academic Director for Assessment of Clinical Decision Making at Aquifer. I'm also a hospitalist at the University of Rochester, and I was the clerkship director for 13 years. I'm really pleased to present to you today about Teach to the Test, assessing key clinical decisions with an online exam. I'm joined today by Kirk Bronander, Emily Haury, Jen Reedlin, and Joe Wayne, who are going to share their own experiences at their schools with this exam. This session is sponsored by Aquifer. Dr. Bronander, Dr. Wayne, and I receive an annual honorarium for our work as members of the Aquifer Consortium. Aquifer is a nonprofit organization dedicated to delivering the best healthcare education through collaborative development and research into innovative, high-impact virtual teaching and learning methods. The Aquifer Consortium is made up of educators just like all of us. Internists, pediatricians, family medicine, radiology docs, and other student educators from around the country. Today, we'll be talking about the clinical decision-making approach. This was formerly known as the Key Features approach. We've changed the name to more accurately reflect what the exam assesses. We'll give an overview of the Aquifer Clinical Decision-Making Exam in internal medicine. And 4 of our speakers will share how they use the exam in their own clinical teaching and assessment. And then I'll walk through how to interpret the score reports that schools receive after using the exam. So the clinical decision-making approach actually evolved from taking a long, we call it paper case or patient management problem, and distilling it down into the key clinical decisions. And these key clinical decisions are the critical steps that are necessary to identify and resolve the clinical problem. It can also be operationalized as the steps where students tend to struggle. And it turns out that if you take a typical internal medicine problem and distill it down, you can identify 2 to 3 key clinical decisions. Now, this approach has been used for quite a long time. The Canadians use it in their qualifying exam, and they've been doing so since 1992. So they have a great deal of experience with it. The way we developed our internal medicine exam is first by defining the clinical problems, which were drawn from a blueprint based on the internal medicine virtual patient course, which was in turn based on the CDIM curriculum. We then took each clinical problem and defined the key clinical decisions. And this is a consensus process, and it really is actually quite time intensive to arrive at these key clinical decisions, but it's worth it because it allows us to focus our questions on what's really important. And then the other half of the process is then writing the vignette and the answer options. So here's an example. The clinical problem is gallstone pancreatitis. And our first step was defining the problem and the key clinical decisions. Given a patient with risk factors for gallstones and a clinical presentation consistent with pancreatitis, a third-year student will make the following decisions. Identify pancreatitis as a likely diagnosis, order an ultrasound to look for gallstones, so they're taking the next diagnostic step, and then initiate volume resuscitation and analgesia, so taking the initial management steps. Once we've arrived at these decisions, we then create a clinical vignette. Now, you actually don't need to read all this. It's actually fairly similar to what you might see in most clinical questions as a vignette. There are a few important differences with a clinical decision-making exam. One is that when we describe a symptom or a physical exam finding, we actually use lay language to describe it as a student might encounter in an authentic clinical setting. Another major difference is how we ask the questions. So in this particular one, we ask, what's your leading diagnosis at this time? And the student only selects one option because we want them be able to establish and prioritize a working diagnosis. But then we lock in that answer and we reveal some more information. In this case, we reveal the laboratory studies. So in this point, the student can see the patient has a leukocytosis and they have an elevated amylase and lipase. But they can't go back and change their answer. Then we ask them another question. What action will you take at this time? And then we actually allow them to select more than one option. If we think about it, what we do as clinicians in real life, we often take multiple steps at once. We don't just do one thing. So with the clinical decision-making questions, we allow them to make multiple choices as well. Now, they are allowed to select up to 4, but they're only going to be scored for 3. Now, if you look at the right-hand side, you'll see that we're assessing both clinical decision number 2 and number 3 in this same question. Often we'll be able to separate them out into separate questions, but in this one, we're asking, what are they going to do next? Well, they're going to start their diagnostic workup and they're going to start managing the patient at the same time. So we allow them to do that. So if the student selects each one, they get 1 point for each clinical decision. But if there are multiple elements to one decision, like with a management, they initiate volume resuscitation and they give analgesia. If they only select one of those, then they only get half a point, but they do get some credit for doing that correct management stuff. Now we do allow them to have a gimme, so they can select one additional item that wouldn't be scored. And that's because in real life, we sometimes will do some extra things. It just doesn't count against them. However, occasionally, in some cases, a very small minority, we have what's called a poison option, where if a student in real life might actually be allowed to make that decision and it might cause harm to the patient, then they can lose point for that key clinical decision. However, we rarely use those, and they can still get points for their other clinical decisions. So we shared how we developed and piloted this exam, initially with a small number of schools, and then we conducted a validation study at 8 schools. So at that validation study, we had 759 students taking the exam, and 515 of those students actually provided their shelf exam scores so we could correlate. We recognize that most clerkships do use the shelf exam. And what we found is that there is a positive correlation between students' performance on the clinical decision-making exam and their performance on the shelf exam. But that was a mild to moderate correlation. So it does seem that we are assessing something different from what we're assessing with a shelf exam. We performed psychometrics on this as well. For the initial validation study, it had a reliability of 0.52. So that's consistent with what you might use with a moderate stakes exam, but not a high stakes exam. We've since done some reviews and updates, and that has increased to 0.74, which is closer to what you would use with a high stakes exam. Now, discrimination, in case you're not familiar with this term, discrimination tells us how a student might perform on any specific question on this exam. And you generally, actually, unlike in real life, you actually want discrimination. So positive discrimination is actually a good thing with an exam. And what you want is if you look at one question, you want the majority of students who get that question correct to also do well on the exam. If it's the students who perform poorly overall, who do better on a particular question, that would give you a negative correlation. So you want this to be positive. And we did have a very good discrimination on this exam. It was 0.27 on the initial version, and it has since improved to 0.35. So I'm happy to now hand this off to Dr. Bronander, who's going to talk about his experience at University of Nevada at Reno. Thanks, Kirk.
Hi there, my name is Kirk Bronander. I'm a professor and I'm the director of the curriculum for years 3 and 4 here at the University of Nevada, Reno School of Medicine. And I was asked to talk a little bit about the CDME exam and our experience here at Nevada. So we give this exam in our clerkship, which in a non-pandemic time is about 8 weeks long. It's one of 2 exams we give in our clerkship. So we continue to give the shelf exam and then we give this exam. It's worth 5% of the student's grade. And we feel like it provides a different form of assessment, which is why we wanted to do this. We are trying to move away from just having a shelf exam and faculty and resident evaluations and have a few other ways that we assess students. What we have found is that during orientation, it's very important for us to describe this exam and describe why we're giving 2 exams to the students. We feel very strongly that we need to walk through a sample question with the students so that they understand this exam format. As Val described in the last session, this is a very different format for students and something they mostly haven't seen before. So it's important for us to walk through a question and help them understand it. We also tell them that seeing patients on the wards or in the clinic is the best way to study for this exam, and we feel like that is true. We feel like if the students have seen some examples of the types of patients that are described in this exam, it goes easier for them. As far as takeaways and overview, our students have given us some mixed reviews of this. Some of them like it, some of them don't like it. The format is very unusual for them, and some seem to be overly concerned about their grade, even though this is only worth 5% of their grade. I think part of that is because they've never taken an exam quite like this before and are unsure of how to study for it, as mentioned earlier. The exam has been very interesting for us to see how students score. Some students score better on this than the shelf exam, and some students that score well on the shelf exam score well on this one as well. I did want to tell you about one student we had who didn't score very well on the shelf exam, but was strong clinically, according to our clerkship director, and did very well on this exam. And the clerkship director was able to put that in her summative comments section, which I think really helped her overall and helped describe her as a good, solid clinical student. So overall, we've had a positive experience. We plan on continuing to use this exam going forward. I'm now going to turn this over to Dr. Joe Wayne for the experience at Albany. Thank you.
Thank you, Kirk. I'm Joe Wayne. I'm the clerkship director and associate program director for medicine at Albany Med. And I'm going to tell you what our experience is with orienting and using the CME at our institution. So during general orientation for the clerkship with the students, I kind of go over the purpose of the exam. I tell them it's a new testing format. It's not single best answer. It's not like anything they've ever seen before. They're going to have multiple things to choose from as they go through. They may actually have to fill in the blanks. I let them know that it is based on aquifer cases. And, but, you know, they don't have to do the aquifer cases to be able to take the exam and do well. I also provide them an article from the Canadian Board of Medicine that kind of goes over the design of the test and gives multiple examples of questions for them to look at so that they can play with it as they will to get used to it before they see it. I tell them it assesses their clinical reasoning, and it's really applying their knowledge to the scenarios as opposed to most multiple choice exercises that they're used to, which is just primarily testing recall and recognition of things. I also let them know that the questions are posed in 5 general categories: as an undifferentiated complaint, identified as an unidentified single problem, multi-system problem, life-threatening presentation, and preventative case scenarios. So on this, I also tell them how that's scored. It's not a typical 1 question, 1 point type of answering. That some of the questions, the answers are weighted such that there may be 3 correct answers, so that each one would be weighted 1/3. And that's kind of just about all I tell them to give them that sense. I tell them that there are sometimes an occasional poison answer. And what that means is that that's usually you picked something that could be harmful for the patient, or perhaps you've done too much testing and kind of overshot what the instructions had given you. And those are some reasons to get a 0 on a particular question, in addition to not picking any of the right answers to begin with. And then lastly, I just show them this article. This is the article that I give them from the Medical Council of Canada, which explains the reasoning behind the test and how the questions are designed, and then provides them examples for each of the different type of scenarios that they might see on the exam. And when I look at how we do pretty much what the national average does. It's usually in the upper 50s. And this is what it looks like across the year. And one of the things I'm happy about when I see this that makes me feel good about using it is that this is the same pattern I see for everything I use to grade the students in the clerkship, whether it's their OSCE, their NVME, their clinical evaluations, they all have the same pattern of improving over the course of the year, with the exception of the fourth rotation. But that we have attributed that to all the activities that go on. Preparing for fourth year is really a distractor for them. And it happens in everything that we measure. So I think it's fairly reliable measure of their abilities in terms of developing a grade for a clerkship, which is why I use it for 10%. So that's my story, and I'm going to turn it over to Emily now.
Thank you, Joe. I'm Emily Haury. I'm the Inpatient Internal Medicine Clerkship Director at University of Missouri, Kansas City School of Medicine. We have a unique curriculum at UMKC. It's a 6-year combined BA/MD program. Our students actually do 3 inpatient internal medicine clerkships. The final one is in their 6th year, and they're working at a sub-internship level during that clerkship. And that's where we have been using the clinical decision-making exam for the past 3 years. Prior to that time, we'd been using the NVME advanced clinical exam in internal medicine. And the first year we used the clinical decision-making exam, students actually took both so we could compare performance and look at the data. We really chose this exam because we wanted to have an exam that was more clinically relevant to the students and just avoid yet another multiple choice exam in this sequence of inpatient medicine clerkships. So after the first year, when the exam was just worth 5% of the grade, it's now worth 30% of the student's grade, and we do grade the exam scores on a curve. To orient students to the clinical decision-making exam, I described the format. I also have a video posted for them on our learning management system where I walk through a sample case and how it's scored, so they understand the multiple correct answer format as well as what the poison options mean. I also post for them and go over the history of the key features exam format, particularly how it's been used in Canada over the years, so that they understand that this is a well-established exam format. As far as advising them to study beyond their work in the clinical environment, I encourage them to study the aquifer cases or other resources that they use to cover the same content as during their core inpatient internal medicine clerkship the year before. So as we've used this exam over the past 3 years, I've realized that students are somewhat uncomfortable with this format just because it's something that they have never seen and experienced before. And some of that uncertainty and associated negative evaluations from the student has really been mitigated by me just providing more information and going over sample cases with them. And I plan to continue to do more of that in the future. I've also done quite a bit of analysis on the clinical decision-making exam scores and how those correlate with other measures that we use to evaluate the student. There is very strong correlation between both the NBME medicine subject exam and also the advanced clinical exam for our students who took both of those during their sub-internship. But we've also seen a small but statistically significant correlation between clinical performance ratings and the key features exam performance. We've also looked at the timing of year that the students are enrolled in the clerkship and how that impacts exam scores. And that was really inspired by our students feeling like they were perhaps disadvantaged by having to take the sub-internship during the time of year when they're involved in residency interview season, because that's a stressful time of year and they are randomly assigned, so they don't get to choose when they're enrolled. We did not find that students enrolled during interview season's performance on the exam suffered, but we did note that students enrolled in the clerkship during the final third of the academic year, the post-match or post-interview season timing, had lower scores on this exam, which we anticipate may just be because those scores perhaps don't matter as much anymore, and they're not as studying as much as they normally would for an exam. With that, I will hand off to Jen.
Thanks, Emily. I'm Jen Reedlin, Assistant Professor and Director of the Medicine Sub-I at the University of Rochester. So we use the exam as more of a formative assessment for the students on their 4-week medicine sub-internship. The goal is really for the students to gain an understanding of where they're at as they start their internship to help guide their studying and their patient caseload. So it's not used as part of their grade, and students are told that at the beginning at an orientation on their first day and through an email that comes out before the start of the rotation. So again, the exam is given on day 1 of their sub-internship. The course coordinator who proctors the exam gives them the orientation to the exam using the instructions from Aquifer. Again, students are told it's not part of their final grade. It's really just their effort and their professionalism in completing the exam. And then the results come back within about a week. So I'm able to review their overall results and then their top 3 and bottom 3 cases with each student during their mid-rotation feedback session. Going over the top 3 and bottom 3 cases for every student allows all students to get some positive feedback as well as some constructive feedback, regardless of their overall performance on the exam. This helps students target their studying and patient caseloads during their sub-internships, including the ones in the spring as they're approaching intern year more closely. I've seen increased satisfaction with the students taking it at the start of the rotation versus the end. And then students doing night float were previously disadvantaged because they would be coming off of their night shift and then coming in during the day to take the exam. So their overall performance was lower than expected. And now that it's taken on the first day at the start, when everyone is still on a day shift type schedule, the performance is more balanced and as expected. I'll turn it back to Val for the score report.
Thank you so much for sharing your experience at your schools. I think that's really helpful. Now I just want to walk through the score reports that your schools and your students will get. So the clerkship coordinator and clerkship director get an overall score report, and this comes back within 48 hours. And it will show you the mean for your particular cohort of students, the standard deviation, and then the range of low and high scores. And then it'll show you the score for each of your students in your cohort, as well as the time that they spent on the exam. You will also receive an individual student report, and this is arranged by case. So the exam consists of 15 cases, and each of these patient cases has a patient name. The student will see their performance on that particular case in the 3rd column. And if they feel like they need to go back and study and learn more about that particular case, for example, the Mr. Jimenez case, they can go back and study. What we do give them is the number of the corresponding Aquifer case. So if the student who performed poorly on Mr. Jimenez wants to go back and learn more, they can study Aquifer case 1. Just a few things to know about the exam. As I mentioned, it is aligned to the Aquifer Internal Medicine Virtual Patient Course, which is in turn aligned to the CDME curriculum. We have intentionally kept it brief. It's a 75-minute exam given online. And we did this because we do recognize that schools often are using other exams as well. And we wanted to make sure that this is one that could be dovetailed with a second exam on the same day. And the score reports are returned to you within 48 hours. If you have any more questions, you can get answers in a few different ways. You can go to the Aquifer website or email exams@aquifer.org. You can also visit us at our booth. And right now we're going to open it up for questions. Great. So I will say welcome then. Hi, I'm Val Lang. I'm a hospitalist at University of Rochester. I was clerkship director for 13 years here. And I am really pleased to be here. Thanks for joining us. I'm joined by Kirk Bronander. Come on, wave hi. Jen Reedlin and Joe Wayne, who you saw on the video. I think Emily will be joining us as well. And from Aquifer, we're joined by Anthony Wilson and Eileen. I always butcher your name, Eileen. So
Oshevsky.
Yeah, and Megan Hotailing.
Mm-hmm. And Val, if it would be helpful, I'd be happy to moderate the questions, read them from chat for you all, so you don't have to follow that and you can just answer. Would that help?
Yeah, that'd be great. Thanks, Eileen.
Terrific. So we have a question in chat now. It says, for the 4th year, it would be interesting to give an exam to all of the IM sub-Is right for the 4th year. Could give early formative feedback and guidance, taking sub-I off service every first day, and could see my students at school not liking that. So I guess the question is, does anybody have any feedback related to that?
Probably Jen Reedlin can answer that because you do something like that.
Yeah, so I include the exam as part of my academic half day that I have on the first day for my medicine sub-I. So it gets incorporated into that time. So all the students know that they're not going to be with their team on that first day, but that's the only day I take them away. And then I do mid-rotation feedback with them. And that's when I review their score reports with them and go over maybe which aquifer cases they should review, or think about different patients that they could pick up or try to ask for on their team moving forward to kind of help guide their learning.
Excellent.
Emily,
Thank you. Oh, go ahead, Val. Sorry.
Do you have something to add to that, Emily?
So we use it on our sub-internship as well, but not for formative purposes like Jen does, but for our final summative exam. So I think it's a very appropriate, if you don't want to add it to your core clerkship and have a second exam for your year 3s, it's a very appropriate level for a year 4 medical student. Gives them a little extra challenge to use this new format that they haven't used before.
Great. Thank you. We have another question about actually using it outside of internal medicine. It says, for programs with sub-Is and other disciplines besides IM, do you think it could be appropriate to administer this exam since you're measuring clinical reasoning, which might be considered generic as opposed to content?
You know, it's an interesting question. This actually, this exam it is very content specific. So what we consider a key clinical decision is entirely embedded and linked to the clinical problem. So it's very content and context specific. That being said, the content that students have to learn with acute care internal medicine is very similar to what they have to learn to be a surgical intern. When they're doing very little surgery, they're actually doing a lot of internal medicine. So I think that that part, this exam covers both some inpatient and outpatient, but to that extent, I think it would be useful to surgery sub-Is, but we have not actually assessed it in that setting. But it would be an interesting, and it would be reasonable to argue to try to do that.
That's great. Anyone else want to weigh in on that, or should we go to the next question? All right, thanks, Val. The next question is, for those of you that curve the exam, how exactly do you curve the score? We've been using the CDME for the past year and have been wondering how to incorporate the score since the average for our school is lower than the MBME shelf exam.
That's not just your school, by the way, Rini. That's all schools. The mean score for this exam is in the low 60s, and that's in part due to the way that it is scored. So if your students are seeing that lower score, it's not because they're doing poorly. It's just because that's the way that the exam scores out. So, but I'm curious with any of our panelists who's curving.
So we just divide the percent score by 80. So if the student got a 65%, for example, on the clinical decision-making exam, we just take 65 divided by 80 and then convert that to our clerkship grading scale. And I started that based on some statistics that Val sent me several years ago when we started using the exam, and it's worked out well, kind of in alignment with our grading scale. I have only ever had one student out of 300 plus at this point who exceeded 80% on the exam, did very well.
Anyone else grading on a curve?
So I believe my clerkship director at our school here uses the standard deviation. So I think if the student scores one standard deviation above the mean, then they get a little bit higher score. If they're one standard deviation below, they might get a slightly lower score, and then everyone else is kind of in between, which essentially I think means their grade is not severely affected. And if they do really well, they're sort of given a bonus, and vice versa. So I believe that's how she does it.
Great.
I use a standard deviation method too, but I also weight everything, including the standard deviation, by the same weight. So I use the CDME for 10%, and so when it gets converted to the Z-score for standard deviation, I just multiply that Z-score value by the weight that I use to calculate the final grade.
Great. All right, thank you. We've got another question. How is the MBME exam different from OCFR exam? I saw examples of the OCFR exam in your presentation. Can you give an example for an MBME exam question?
So I'll take the second question first. The NVME exam is proprietary and secure, and I'm not allowed to share questions from it. But that being said, the NVME exam they're familiar to you. The questions are single best answer, multiple choice questions. They have a vignette, and the student can typically pick from 5 different options and pick one single answer. So the format is having a clinical vignette will seem familiar, but the way that the questions are developed and how the actual lead-ins and answer options are determined is very different. So and you saw the example of the clinical decision-making question. The first thing that we do is we spend about half our time figuring out what's important to ask the student. And so you say, if we have this clinical problem, what do you really need to do to solve this problem? What's going to be really important? And where are the things that students struggle? And so we really have to dig into our experience with teaching students and assessing students to make those calls. And then we come to consensus. So that's half of developing those questions for the clinical decision-making exam. And then we develop the case scenario and the lead-in and the answer options. And with our answer options, it's a little bit more like real life in that you can actually do more than one thing at a time with most of those cases. And you can lock in an answer and let the case unfold and answer the next question. What do you do next? So that's something that is not typically done with a multiple choice exam like NVME. Typically, each scenario is a standalone question, and it doesn't unfold.
Great. Thank you, Val. Next question. Could you share a little bit more of your experience with using this in addition to the NVME, and how either reconfirms the NVME, or does this help to offer perspective or preceptor evaluations and account for those factors that impact student evaluations, but may not correlate with different clinical skill levels?
So I'll take a stab at that, and then I'd love to hear from the rest of the panelists too. So the first thing to note is that when we did the original validation study at 9 medical schools, we actually were able to obtain the shelf exam scores. That was part of our IRB. So we were actually able to compare students' performance on the clinical decision-making exam with their performance on the shelf exam. And so what we found is that there was a positive correlation, but it was kind of weakly positive. It was somewhere around 0.2. So that means that we're actually assessing something different than what's being assessed for the shelf exam. So because it is different, it does make sense to actually combine the two. And it doesn't necessarily replace the shelf exam, and it was actually never intended for that purpose. But we also recognize that many schools require the shelf exam. And so we made the exam short. We made it 75 minutes so that if you want to administer both in the same day, you can very reasonably do that because it only takes 75 minutes to do this. And if you have to give your students accommodations, you can still do that within a reasonable assessment day.
And Kirk, I know you're using both. Do you want to talk about your experience on LV?
Yeah, sure. I can talk briefly about that. I echo what Val says. I think to me, the shelf exam is mostly, the MBME exam is mostly a knowledge exam, really. It's based a little bit on factoids, and that's why students have learned over the years if you know your students, they tend to love those question banks where they just go through tons of little questions with sort of facts. And that does help them, I think. This exam is quite different, and it's very difficult to guess on this exam. And so it's very much more realistic in the sense that, as you saw, you're asking the student to pick from a menu of different tests, for instance. So my feeling is that if the student has had a patient with pancreatitis, was the example that Val used, they're going to feel pretty comfortable picking out what to order. And if they didn't have that patient and forgot to read much about it and didn't really think hard about it, it's going to be very difficult. And so I feel like it really does focus on the clinical aspect. And, students so far, they don't know how to study for it. So they're a little uncomfortable with that, I think, sometimes, where they know how to study for a shelf exam. They just cram tons of knowledge into their heads, right? So this is a little bit uncomfortable for them, but I think it's a really fair exam, and it's very clinically based. That's been my experience.
That's actually how we came up with the name for this webinar, Teach to the Test, because we wanted to tell you it's okay to teach to this test because you're telling your students to learn from their patients, which is what we're trying to assess.
That's great. We have another question. Anthony, you might be able to weigh in on this one, is where can we find sample questions, or do we just use the case from the publication?
Sure. We have a handout that provides at least one example that you can give to your students to give them an idea of what they'll be experiencing. For faculty, we sometimes do allow faculty to have a sample exam sent to them so that they can at least let the students know what to expect. And we are working on expanding the handout so that there are a few more examples of what to expect on the exam.
Great. Another question. For the sub-Is, I think Jen or Emily mentioned sub-Is later in the year do worse. This could be learner fatigue, already matched, etc. You would think or hope that they improve their clinical decision-making over the fourth year. Any thoughts on this?
Go ahead, I'll let you go.
Jen, I think we agree. But just, and I don't know if you've seen the same trend, but I mentioned here, and I'll put in a shameless plug for my poster. Maybe I can put the link in the chat where I go into a little more of the different student factors we looked at with performance on this exam. But we saw a pretty significant decline in score in the kind of February through May clerkship students. Which I strongly am suspicious is related to just lack of effort on the exam and preparation, since their grades no longer count at that juncture.
I haven't noticed a big trend, but just overall, I think there is the post-match. And for us, the students who aren't going into internal medicine, who are maybe doing a different specialty, but are still taking a medicine sub-I, so maybe they're just not as invested as well, or doing it in the spring too. So I think that factors in as well. But there hasn't been a big drop yet.
Senioritis.
Yeah.
All right. We have no more questions in chat. We do have a couple more minutes. So I want to encourage us, there's still a number of people online to go ahead and drop questions in the chat. And in the meantime, I want to make sure that we remind people of how they can, that the access to this exam is available free if you're a subscriber to the OC for Internal Medicine course. So no need to pay for anything additional. We're not for profit. It's really important work that we want to get out to everybody. So you can reach out to us at, what's the email, Anthony, if they have questions?
exams@aquifer.org.
exams@aquifer.org, and you can connect with Anthony and his crew if you subscribe to the internal medicine course and say, okay, I need to figure out how to get access to this for my program.
And if you are already subscribed and would like to request the exam, there's a link in the chat right there that you can go straight to and request it.
Okay, and that was the next question, Anthony, is there an email for the sample exam you were speaking of for the clerkship directors?
Yeah, you can send to exams@aquifer.org and they'll direct it to me and I'll get you all set up.
Anthony will take care of you.
Yes.
Is it proctored? Anthony, do you want to take that?
Please, yes. We prefer that it is proctored, yes. I can't say more. Yes, we do prefer that it be proctored. It is easy to proctor in terms of if you are working remotely, we have systems set up for that. And when you request the exam, we'll give you all the details you need to know so that you can proctor it remotely. If it's on site, obviously, you can proctor from a centralized area.
Okay.
The remote proctoring has been very helpful during COVID. We couldn't all be in a room, so that was great.
How did you do remote proctoring, Jen, during COVID?
I wasn't the one proctoring it. It was our course coordinator, but everyone just had to have certain settings on their computer and a camera on them while they were taking the exam. They were able to do it.
Yeah, we didn't have any problem with the remote proctoring at all. So it went really well.
Great. Another question, how do you use the information regarding this exam to inform your MSPE or department letters? Is it used universally or only as a positive addition?
Kirk and Joe, you actually give it before the letters go out. So do you want to speak to that?
Yeah, I mean, I don't call it out separately. I use it more in conjunction with when I'm putting their final comments together. I tend to break them out as reporter, interpreter, manager, educator. So I look at the interpreter part as, and I just try to use the comments I get from all the evaluations and look at how well they did on the CDME compared to what they said. And I also will probably look at their written H&Ps to see if their clinical reasoning seems to hold up and be steady across it. So it just helps me sort what comments I want to use when I'm putting their final evaluation together.
Yeah, I wish I could speak more confidently about that. I am no longer the clerkship director, so I am not 100% certain. I know she uses it in a positive way if it correlates with their evaluations, and was kind of the example I used, but I don't think she universally comments on it. Is my feeling on that.
I mean, we do include it in the discussion about what goes into the grading profile, you know, the calculation of the grade. So it's in there that we use it for that. So.
Okay. Val, this one might be a question for you. There are 30 cases, I think. How do you choose which ones to be tested?
Yeah, so so when we developed the cases, we developed, they were based on the virtual patient instructional cases. We actually developed two assessment cases for each instruction case. And the instruction cases were in turn based on the CDIM curriculum. So, so what we did is once we had them all developed, we made a blueprint so we could make sure that we balanced out inpatient, outpatient, diagnosis and management, and different organ systems or areas. And so we balanced out each exam form based on those. So there's a breadth of topics that are assessed in each exam form. There are actually, we have actually 4 exam forms. We have 2 that are currently being used, and each of those has 15 cases in it. But we have a committee that's actually reviewing, revising, and updating the cases from the remaining 2 exam forms, so that we'll be starting to circulate those at some point soon as well. But yeah, that's basically how they were chosen. They were the high performing cases, and they fit the blueprint.
Excellent. We have no other questions in chat, and I think we are just about at the end of the time. One just popped in. Any experience to use it with a clerkship? I don't know if we could answer that quickly, and then maybe Val, you could close us out. Thank you, everybody, so much.
Yeah, so 2 of our panelists use it in the clerkship and 2 in the sub-I. Kirk?
Yeah, so we use it in our clerkship as 5% of the grade. We wanted just an additional way to assess students besides just the shelf exam and some evaluations. And so we just feel like getting more and more evaluations is going to give us a better overall view of a student. And so this was just a great way to add a little bit different evaluation for us.
Great, thanks. Thanks so much. These are great questions. And I'm moving over to the booth. So if you still have some burning questions that you didn't get a chance to ask, just come on over to our booth. I'll be there for the next half hour. It was really great to see all these familiar names, and I hope you're enjoying the meeting.